Good morning, everyone. Welcome again. Please move closer to the center of the room so we can get started. Okay, as we settle down, we're going to get started. Thank you so much for joining us. Welcome, everyone. We are thrilled to have you join us in this transformational conference and experience. We truly are grateful to be joined by so many maternal and child health champions in our community. My name is Regine Kansky. I am the Vice President of Operations at Broad Healthy Start Coalition. And like most of you in the room, for the last 25 years, I have devoted my time, energy, and endless passion to improving maternal and child health outcomes for families and our community. I'll be your point person today for this amazing breakout session. I'll be taking care of your logistics, but before we begin, a few housekeeping items. We have index cards that will be distributed by our team. We have Mr. Jean Robert and Ms. Bibiana, and they will be distributing index cards, and the purpose of these index cards is for you to write down a question that we will collect from you at the end of the session. If we have time, we'll address a couple of questions. If not, we will follow up with you after the conference for your questions. A reminder that please, we will put up the QR code for the evaluation. The evaluation is extremely important to us. We value your feedback. Please take a moment. At the end, you will see the QR code up. Take a moment to scan that QR code and make sure that we are ready for completing evaluation. If you are not able to scan it from the screen, Jean Robert right here has a printout that he can provide you so you can scan it from your phone. Everything is electronic. We are very high tech around here. Thank you very much. All right, so if you need CEUs, it is essential that you complete the evaluation. Without the evaluation, your CEUs will not be processed. Okay. Preconception care. Preconception care is a set of interventions intended to identify and to modify biomedical, behavioral, and social risks created by community conditions in women of reproductive age. The goal of preconception care is to improve pregnancy outcomes and women's health in general through prevention of disease and management of risk factors that affect pregnancy outcomes and the health of future generations. We are thrilled to bring you this presentation, and because the purpose of this session is to understand the goals of pre-pregnancy care, understand the significance of birth control access in public health, and the role of enhancing maternal and neonatal outcomes, and evaluate approaches for preventing and addressing STIs in pregnant individuals. Our amazing speaker this morning is Dr. Kathleen Green. She is a board-certified, Army-trained OBGYN who works full-time for Maven Clinic, the world's largest digital clinic supporting women and family health. Dr. Green supports women and families in all stages of their lives and spent 4 years in an active duty Army OBGYN and 5 years in academic medicine. She also works part-time at Advent Ocala doing OB hospitalist shifts. She loves working for Maven as it gives her the opportunity to meet women where they are and allows her to bridge the gap between traditional and brick-mortar medicine, which often leaves women feeling unheard and unseen. Please, let's give a warm welcome to Dr. Green.
Thank you so much. I'm so happy to be here today. I wanted to start out with just telling you a little bit about myself. So as you heard, I've done a little bit of everything. My grandmother was a family physician in my hometown. So she was the first Black female physician in Midland, Texas, where I grew up. I was delivering babies in high school with her. So This is what I was born to do. And, as Chanel talked about, we've been here before. We've seen this in history. She was desegregating high schools and clinics when I was growing up. And at dinner last night, Monica said something that was really important. The world may change, things may get crazy, but what we do is the same. We care for women and families. We care for women and families. It may get a little bit harder, but it's been hard before. Now we have more resources. So my hope today is that we talk about ways to make it easier to care for women and families, and we don't forget why we do what we do. I know many of you feel like this was a calling, and it likely is, but it also doesn't mean that it's not hard, especially in Florida, especially in the South oftentimes. But let's not forget that what we do never changes. Our goal is to improve the life of women and families. I will try to leave plenty of time for questions at the end. So preconception care and beyond. No financial disclosures to report. These are my learning objectives. Explain the goals of pre-pregnancy care, including key considerations, understand the significance of birth control access, evaluate approaches for preventing and addressing STIs. I will have some data in here. I'll skip over that a little bit because we kind of know about the data, but I'll talk about why that data is important and how it can really change how we care for women and families. Who needs preconception care? Everybody. Everybody needs preconception care. I think that we often think that we can only do it in annual visits or women that are coming to see us. But we can ask about this at immunization visits, childcare visits, shop visits, STI visits. We can ask male partners. One of the ways that I often ask is, are you thinking about becoming pregnant in the next year? I also like to ask, are you thinking about expanding your family? Because we have to remember that they may not be birthing a child themselves. They may be fostering. They may be adopting. This is important because we want to think about vaccine status, right? We want to think about making sure that they're vaccinated and their titers are up to date for measles, mumps, and rubella, especially with the new things that are coming out, and because we can't always trust that people have been vaccinated. So this is a really great opportunity. Are you thinking of expanding your family? Are you thinking about starting a family in the next year? And we can ask those questions, leave them open-ended, because we also don't want to impose our own beliefs on other people. Goals of preconception care: identify, minimize, and educate. We want to identify risk factors that we can prevent and treat. We want to minimize complications, and we want to really educate. So how do we identify? We'll tackle these one by one and go through them. Identify. You really want to ask about any health conditions that anybody has that may impact their care. One of the questions that I always like to ask is, what medications are you taking? Are there any medications that you don't take? Are there any medications that are prescribed to you that you should be taking, that you aren't taking? I think that sometimes that we forget that oftentimes there are barriers to care. I worked in academic medicine for just over 6 years, and one of the things that always struck me with our residents, who are amazing, OB/GYN residency is one of the toughest residencies that you will ever go through, but we often forget the barriers to care. And so sometimes we label patients as non-compliant when sometimes they are trying to be compliant. But so when you ask them, are there medications that you should be taking that you aren't taking, and why? Maybe the prescription wasn't sent into the pharmacy. Maybe it was too expensive. Maybe they didn't have rides to get to the pharmacy to get the medication. So we always have to ask that question. Don't just ask, what health problems do you have? Have you ever been told that you have a health condition that you're not aware of, or maybe you don't believe? Because we also have to remember that there's a lot of fear of medical providers as well. So maybe they were told that they had an infection. Maybe they were told that they had sickle cell. Maybe they were told that they had lupus, but they didn't really believe it. And so that's a really great way to open up the conversation. Have you ever been told you had a health condition? Did you have complications in your prior pregnancies? Do you need help getting your medications? These are really important things to ask. Access to care. Do you have a healthcare provider that you see regularly? Do you feel comfortable with them? Do you feel heard and seen? The goal of preconception care is to make sure that their next pregnancy is safe, less complicated, but also that they're with a provider that they feel heard and seen. As ridiculous as this sounds, it's very hard to find an OB when you're pregnant. Like really, really hard. So what we can do is when they aren't pregnant is we can help them find a provider. Sometimes it can be a 6 to 9 month to 12-month waiting list. There is an OB shortage. I practice in Alachua County, that's where I live. I do my shifts in Marion County. It is hard to find an OB. When we look at the statistics for women entering care in the first trimester, we've had to change that. Women are trying to get care in the first trimester. There are no visits. There are no OBs for new patients. And so what we have to do is make sure that we're helping them get care before they need care. So if that's an FQHC, if that's a midwife, if that's a family practice provider. So these are questions that we ask. And if you have an OB, do you want them to take care of you in your next pregnancy? If not, let's help them find someone that they feel comfortable with, because we know that if a woman has a provider that they trust, they will have better outcomes. If a woman has a provider that looks like them, they will have better outcomes. Data consistently shows if they have a provider that speaks the same language that they do, their outcomes will be improved. And so we need to make sure that we are asking these questions while they're not pregnant, so that we can make sure that when they are pregnant, they have the care that they need. Identify. I also like to ask, were there complications in your prior pregnancy? Oftentimes, no. So what you can ask is, did the baby go home from the hospital with you? Because sometimes it can be a blur, and you may not remember everything, because we all say that when we're in labor, I'm not having another baby, that was too painful. You forget everything that happened. If the baby didn't go home from the hospital with them, there was a complication. What was that complication? How can we prevent that in the future pregnancy? Did you have a C-section or vaginal delivery? How do you want to deliver your next baby? Do you want another C-section? Do you want to try for vaginal delivery? I want to put a little asterisk by this, because many women want to try for a vaginal birth after a C-section. We know that that's safer. We know that it has less complications. We support that. That's great. That's wonderful. Not every hospital can do that. We have to educate our patients. We have to educate them that what they want, we want that for them. But if they live in a rural community at a community hospital, that may not be an option. And so when patients come during their pregnancy and they say, my doctor, I don't want to see that doctor, they don't allow me to have a VBAC. It's not that they don't allow you, they are not equipped to handle that. So that may mean transferring them to a higher level of care, but that can sometimes mean driving to a bigger hospital. This is about educating, empowering, and encouraging women to ask the questions. We'll get to how we can empower women, but we really need to ask the questions first so that they have time to really process this. When did they start prenatal care? They may say that their pregnancy was uncomplicated, but if they started prenatal care in the 3rd trimester, that's not uncomplicated. And so these are really important questions to ask. Just asking if they had complications, it's not a really good question. So dig a little bit deeper and ask those other questions as well. I also like to ask, do you have any concerns about becoming pregnant? Is there anything you would like to do differently this time? Women consistently say they do not feel heard, they do not feel seen. When you ask open-ended questions, it gives them the opportunity to share their experience. And I wholeheartedly know that we are really, really busy. But so even when I have a 10-minute patient visit, I try to at least ask 2 open-ended questions and give them the space to talk. And if I run out of time, I am so sorry, we're out of time. But I'm scheduling another visit for you in a week. It's going to be a longer visit. Let's talk about this in more detail. Or write down the questions. Here's some questions I want to talk about in the next visit. Let's talk about this in our next visit. They need to feel heard. They need to feel seen. You have to build that trust. And so we want to make sure that we're creating space for them to tell their stories so that they trust us, because you cannot educate them or empower them if you're not making space for them to tell their stories. We really want to make sure that we're asking open-ended questions. Address. So now that we've identified, we have to address. We have to screen for alcohol and illicit substances. Many women, many people know about the risk of alcohol in pregnancy. Marijuana is the #1 illegal substances in the United States that is used during pregnancy. It is just as dangerous as alcohol use, and we have to educate our patients. We have to talk to them about the use of marijuana in pregnancy and preconceptually. There is significant withdrawal that can happen during pregnancy if they've been using marijuana on up until the time that they become pregnant. So we have to have those conversations. And I always say there's no safe amount of alcohol in pregnancy. We also have to say there is no safe amount of marijuana use during pregnancy. There is no safe amount of marijuana use while breastfeeding. It should not be a determinant to not breastfeed, absolutely not, but we have to let women know that marijuana, THC, absolutely passes into the breast milk, and it affects baby's developing brain. Marijuana use during pregnancy increases the risk of miscarriage, stillbirth, preterm birth, serious complications, and significantly affects brain development. Babies are less likely to meet their developmental milestones for women that use marijuana throughout their pregnancy. This is the opportune time to educate and address. But remember, if you haven't established a relationship with the patient, they're not going to believe anything that you say. Relationships are first, and then you can educate and address. We also want to screen for intimate partner violence. Do you feel safe at home? Have you ever felt threatened? Because safe at home may be safer than living on the street or living in a shelter. So we want to make sure that we're asking really important questions and not just safe at home. Have you ever been forced to do something that you didn't want to do within the last 12 months? Do you feel like you can voice your concerns to your partner? We really want to ask those important questions so that we can get them into a safe situation if they're not currently in a safe situation. We want to offer genetic screening. Carrier screening can happen outside of the pregnancy, especially for our minority populations. We know that certain conditions run in the family: sickle cell trait, sickle cell disease, cystic fibrosis. We want to make sure that we can offer carrier screening. Insurance usually covers it once per lifetime. So if they haven't been screened in the last pregnancy, or if they presented late to prenatal care before, we can offer carrier screening, and they can get it through typically their primary care provider, and it's screening them for about 200 to 250 different genetic conditions prior to pregnancy. If she screens positive for cystic fibrosis or sickle cell trait, we need to screen her partner. We want to make sure that we're counseling women before they get pregnant so that we can identify these concerns. We also want to assess for STI risk as well. If an STI is in the first trimester, we can treat it. But again, if they have difficulty getting access to prenatal care, let's screen them before they get pregnant. And this is where you can definitely ask, are you using anything for birth control? Are you thinking about becoming pregnant in the next year? And so when was your last STI screening? These are things that we should address. Educate. We want to talk about prenatal vitamins and when to start taking them. A lot of women don't know that you should really start taking prenatal vitamins 2 to 3 months before trying to get pregnant. We want to build up that folic acid in the system. Any over-the-counter prenatal vitamin is great. It does not have to be those expensive subscription services that have to take 8 tablets per day. Any over-the-counter prenatal vitamin is perfectly fine. Talk about healthy lifestyle choices, including smoking. Smoking also significantly increases the risk of complications. We want to educate on these things. BMI. It can be challenging to talk about weight during pregnancy and outside of pregnancy, and so you want to really just state the facts and open it up to questions. I typically talk about BMI. Your BMI was this. Studies have shown that BMIs greater than 35 increase the risk of complications during pregnancy. I talk about healthy weight gain during pregnancy. Based on your BMI, you should gain approximately 10 to 15 pounds during the entire pregnancy. Oftentimes, that is very shocking information. When you ask patients, has your provider ever talked to you about weight gain during pregnancy? Most of them have never heard those recommendations at all. Most women, most of society feels like eating for 2 is a thing. You do not actually need any additional calories in the first or second trimester for most women. But on the reverse side, we also have to talk about low BMIs as well. We have a lot of patients that are food insecure. So we want to talk about extra calories and healthy calories. Do you need help getting food? One of the things that I always do when I have a patient presenting with dehydration, nausea, vomiting that's underweight to OB triage, do you need food to go home with? The majority of patients say yes. When a patient presents with dehydration, do you have water to drink at home? The majority say no. If they're having to buy bottled water, That's a problem. Bottled water is really expensive. So we talk about options. We talk about water filters. We talk about different things and send them home with as much bottled water as they can carry. These are questions that you have to ask because you don't know where your patient is coming from. These are things that we can ask when we do home visiting as well. Do you have safe water to drink? Do you need help getting safe water, especially if they have other children at home that are having to do formula, whether they're breastfeeding, staying hydrated during breastfeeding to produce breast milk. These are all things that need to be covered. Empower. How do we empower women? I always like to ask these questions as well because this really gets to the root of it. Do you feel like there's anything missing that would help you have a healthy pregnancy? And listen. Sometimes it's nothing. Sometimes they don't know. But give them space to really think about this. And I ask them almost at every prenatal visit, what do you need? What support do you need? And sometimes it's just, that's the first time anyone's ever asked me that. And I think that it's unfortunate, but we can really change the conversation. We want to empower women to take control of their own pregnancy and their own health as well. And this is how we can ask those questions. What actions do you think that you can take to support a healthy pregnancy? And we can ask if they need assistance. Sometimes this is, if they don't have answers, what about walking for 10 minutes a day? 10 minutes a day. Do they have a place to walk, though? Is there a safe place to walk? Sometimes that's going to the mall and walking indoors, especially in Florida summers. I do not want my pregnant patient walking outside for 10 minutes when it's 110 degrees outside. But sometimes that's walking in the mall with their children. Sometimes that's doing yoga on YouTube. There's a great Cosmic Kids yoga that they can exercise with their toddlers. It has Blue's Clues just to get moving. We know that being active during pregnancy is going to improve their outcomes as well. Contraception. I think everybody should be on birth control or at least have access to birth control. It's hard, though. It's hard to get access to birth control. 31%. That's the unintended pregnancy rate in Florida. It doesn't seem that bad, but then let's break it down. This is 2020 data. The 2023 data came out pretty recently. I wasn't able to put it on the slide, but it's pretty consistent. 19 and under, 63% unintended pregnancy rate, meaning that they were not planning on becoming pregnant and they became pregnant. 20 to 24, 42%. 25 to 34, 29%. And greater than 35, 23%. I automatically assume that when it's an unintended pregnancy that it's a world ending, because for many women that would be, sometimes it's not that bad. Meaning that even though it's unintended, it's a wanted pregnancy. So we have to make sure that we're checking our own bias. I have to check mine continually. And you ask them, if you were to get pregnant today, would that be life-altering and a bad thing? If the answer is yes, let's talk about birth control options for you and your family that align with your goals. We'll get to how to counsel on patient-centered, but you want to ask the question, if an unintended pregnancy would be welcome, then maybe contraception is not the right option, but you have to ask those questions so you can make sure that you're counseling appropriately and not from your own bias. CDC named contraception as one of the 10 great health achievements in the 20th century, which I absolutely agree with. Ensuring widespread access to contraception is important for maternal well-being, but also to worldwide well-being. When women get to choose and families get to choose when, how to become pregnant, the world is a better place. Maternal outcome improves. So many things improve when women are in charge of when and how to become pregnant, and that's only possible by ensuring access to contraception for everyone. Only 30 countries require prescription for birth control. Of course, we are one of the 30%. We're one of the 70% that require. However, do you know that there's an over-the-counter birth control now? Who knows what it's called? O-pill. So there is one over-the-counter birth control currently on the market. It's called O-pill. It's progesterone only. It works well. Side effects can be a little bit of breakthrough bleeding. It's about $19 to $25 per month, which is not that expensive, but that's per 1 month. So you can pick it up from the pharmacy. It's a great option, but many women don't know about it, but that is still cost prohibitive for some. And so it's a great option, but we still have to make sure that women have access to it and know about it as well. Does anybody know how much Plan B cost? $50. It's called the O-pill. O pill. It's progesterone only, so it's effective. It's a good option for most people. Does anybody know how effective the O pill is, though? And what's the sneaky caveat of the O pill? You have to take it within the 3 hours of the same time every single day, or it's not effective. So we have to really educate our patients about it, and it's a great option, but there are definitely more effective options because it's progesterone only. I think that it's also important to go over the mechanism of how birth control works to make sure that we're dispelling myths about birth control, because that's one of the biggest reasons why a lot of providers, a lot of women aren't on birth control. So most birth control has estrogen and progesterone in it, birth control pills. The estrogen suppresses FSH, follicle-stimulating hormone, blocks ovulation. The progestin inhibits ovulation by suppressing LH as well. So they work in many different ways. There's birth control pills, there's a NuvaRing, there's IUDs, there's an implant that goes in the arm, there's a shot. So whenever anyone tells me, I can't do birth control because I'm allergic. Okay. I bet we can find one that works for you. I bet we can find one that works for you really well. I don't tolerate it because of the side effects. I bet we can find one that works for you. But again, we have to make sure that they want birth control. We have to make sure that they understand the risks versus the side effects of birth control. We want to make sure that we're doing patient-centered counseling on birth control. Here are the benefits of contraception. There are so many wonderful benefits of birth control. So how we can make sure that we're counseling patients is understanding that not all women want birth control to prevent pregnancy. There are so many other options. Maybe their periods are really painful and heavy, and they're bleeding out every single month, and they're missing school. That's a great option for birth control. I had really heavy periods, and my grandmother put me on birth control, and she told me, just so you know, these are not the birth control pills that prevent pregnancy. So don't think that you can go out and have sex. These are the birth control pills that only make your periods and improve your skin. I actually believed her for a few years, too. I'm saying that to say that if we have adolescents particularly that are having heavy, painful periods, irregular periods, these are great counseling options, especially if we have some parents that are opposed to them. Decreases bleeding and pain with menses, decreases the risk of endometrial cancer, decreases the risk of ovarian cancer, reduce maternal mortality. Again, when women can choose when and how to have children, it improves outcomes for the world and for them as well. Health benefits of pregnancy spacing. If every woman was offered birth control before she left the hospital, they would be able to space their pregnancies accordingly. According to the WHO, it should be 2 years between pregnancies. Imagine if every woman was able to get a prescription for birth control before they left the hospital. That is how I personally counsel patients. We'll talk about that in a second. Increase female engagement in the workforce, increase economic self-sufficiency for women. There are so many studies across the world that when women had access to family planning clinics, economic improvement increased dramatically for the entire country because women were more engaged in the workforce. Their GDP went up as well. And so ensuring that women have access to birth control improves everyone's lives. Societal benefits, enhanced access to prenatal care. Women are able to choose, again, when and how to get pregnant. They're more likely to go into prenatal care because their births will be planned. Improve socioeconomic outcomes. We talked about that. Address health disparities. This is the tricky part. So we talk about access to birth control, but what about those rural areas that don't have a provider that they see? There's so many OB and provider deserts, especially in Florida, but it's across the United States as well. In Georgia, for example, 50% of counties in Georgia do not have a single OB or midwife provider. 50%. So we want to make sure that we're giving access to all, not just in clustered areas. For example, in Georgia, Atlanta has the majority of OBGYNs, but those rural areas, women are often having to drive 2 hours to get care from a healthcare provider. So how do we offer contraception? I generally like to ask, what method are you using to prevent pregnancy? Are you wanting to prevent pregnancy? It goes back to that question we talked about earlier. If you were to get pregnant right now, would you be happy? Would it be life-ending? I ask life-ending because for some women, getting pregnant would be life-ending. And so we have to make sure that we're meeting them where they're at and listening to them. I also like to ask if they ever had any difficulty accessing birth control. What difficulties did they face? Have they ever been on birth control that they liked or didn't like? What side effects did they encounter? Before we can counsel them on options, I like to know what side effects they had before. Are they good with taking a pill? Are they not good with taking a pill? Do they want something to last 10 years, 8 years? Would the NuvaRing be a great option? Would Depo Shot be a great option? Depo Shot, which is a pill every 3 months, is not a great option if their closest pharmacy is 3 hours away. Who's going to give them the shot? NuvaRing is not a great option for my deployed soldiers because it has to be refrigerated. If they don't have electricity, NuvaRing is not a great option. You cannot give them a year's supply if they cannot refrigerate it. If they have unstable housing situations, NuvaRing is also not a great option. These are the things that you have to know about your population before you can adequately counsel them on birth control. We also want to talk about misperceptions about birth control. There is no birth control on the market that causes abortions, period. Nothing. Do they need something that they need to potentially hide from their partners? Does their partner not want them on birth control? Maybe an IUD is a really good option. We have to trim an intrauterine device, and we have to trim those strings super, super short so their partners cannot feel them. Maybe an implant in the arm, the next one on is a great option because their partners will not feel them as well. You have to ask what's going to be the best option for them and their families. How to offer it. A 2023 study showed that 45% of women faced at least one barrier to accessing contraception in the previous year. Patient-centered and trauma-informed. Patient-centered means going with the patient first and not with our own misperceptions. And so we really have to ask the patient what works for them. Again, my bias, I'm an OBGYN. I think everybody should be on birth control, but not everybody believes that. Sometimes there are religious beliefs that don't support birth control. I want to support whatever a woman believes in. So sometimes that is natural family planning. So we talk about that as well. How do we do natural family planning? You can avoid intercourse on these and these days. We go over ovulation calendars. We talk about those things. But it's also about education. We can't do natural family planning if your periods are irregular. And so there's a lot of education that goes along with that as well. We also want to make sure that it's trauma-informed. There are lots of misinformation, but also misperceptions. We also cannot offer birth control to women that do not want it. There's a lot of historical trauma involved with women of color and forced sterilizations. I always ask when a woman presents to OB care, do you want to have more children? If the answer is yes, conversation's over about permanent sterilization. But women need to know that that is an option, but we absolutely can never force our beliefs on patients. If a patient is having her 6th or 7th C-section, it has to be a conversation. If she wants more children, the conversation is done. No woman should ever feel coerced into permanent sterilization. There are really, really great, reliable, non-permanent birth control options, and we want to make sure that our patients are informed of all of their options as well. Barrier. We talked about misperceptions, IUDs, cost, and access. Improving access. So making birth control available at healthcare facilities same day. There should be no waiting period. If a woman presents for an appointment and she wants an IUD, give her an IUD that same day. We used to wait until they were on their period. You don't have to do that. Do a pregnancy test that day, ask about the last time that they had intercourse, place it. You can do STI testing that same day. Even if the STI test comes back positive, you just treat them. If a woman is forced to wait, the chance that she will get an IUD is increasingly low. So we want to make sure that we're doing it that same day. Improving access to pharmacist-prescribed contraceptives. Florida does not allow that, but 22 states do. That would be something that we could offer. A lot of states allow pharmacists to prescribe birth control. Pharmacists are very well educated on side effects of birth control. A woman should be able to go to the pharmacy, want birth control, follow up with her doctor in person. Use of telemedicine. I do telemedicine full-time now, and that's another great option for women to get birth control. The other thing that I always like to talk about is pelvic exams are not required for birth control. One of the things that I often hear is somebody needed to get a pap smear for birth control. Yes, we want pap smears. We want women to get pap smears. But if a woman comes in and she hasn't had an annual exam in 13 months, some doctors will hold that birth control prescription hostage. That's not the right answer. Give them an appointment and give them a refill of their birth control. We should not be making women jump through hoops to get birth control. We should give them their birth control prescription. Improving access. How many of you know about the federal form for permanent sterilization? The federal form is required for women that are on Medicaid. They have to sign it at least 30 days before they get a tubal ligation at the time of delivery. And that's great, and it's done because of the forced sterilization of women of color. We want to make sure that women understand their choices and that they're being counseled appropriately. So they have to sign a federal form to get a tubal sterilization. The problem with this is that when a woman presents with limited or no prenatal care and they're having a C-section, I want a tubal ligation. It's her first prenatal visit. Can she get a tubal sterilization? She cannot. What happens? She doesn't get her tubal sterilization. Pregnant again. No prenatal care again. Presents for her third or fourth C-section. What happens? It keeps happening. What do we do? There are certain situations where you can do it if they're preterm, but what we need to educate our patients about is when we do that home visiting service, have them sign the federal form. Have them keep a copy of it. If they present to one ER visit, have them sign the federal form. If they present to a pregnancy resource center, have them sign the federal form. I'm sorry? It's a good question. The federal form will likely never be changed just because of the history of coercion for women of color. It's really to protect women, and there are some providers that will do that as long as the form is signed and there's a 72 waiting period. There's some nuances around it, but we as OBs can really get in trouble with the hospital system. So what I encourage is I educate all of you about the federal form. So if you're seeing women that say, I wanted a tubal, but I didn't sign the federal form, have them sign it, scan it into their record. And every time you see them, you can have them sign it again and have them keep a copy of it. Most of us, if we have a documentation, because if this is the first time that we're meeting them and they say that they want a tubal, we don't want them to regret it. So we want to make sure that it's the right decision. So if we have them sign it in OB triage, they come back a month later and they've signed the form, they can get their tubal ligation. And so it's a little bit tricky. You can ask. It's a really good question. So I'll leave my cards and I can email you the federal form. So all hospitals have the federal form, but it's a great way that we can give it to you as well. And when patients know about the federal form, I encourage them, when we sign it, I give them a copy of it so that they have it with them, so that if they want a tubal ligation, and anybody can counsel them on it, and doctors will be much more likely. Sometimes doctors don't get them to sign it as well. And so you can advocate for your patients. Sign that federal form at your doctor's visit. Sign it at the pregnancy. Sign it whenever you see your OB. Ask them if you want a tubal ligation, have them sign it, give them a copy of it as well. And that's one of the ways that we can really advocate and educate for our patients. Immediate postpartum IUDs. We can place Mirena IUDs immediately after delivery. We can do that. If a patient, for example, wants a tubal ligation, she doesn't get it, I can offer her placing an IUD after delivery. It's good for 8 years. And for some women, that's a good enough option because we want to prevent pregnancy. And so there are ways that we can do it. I offer all patients that I see on postpartum rounds birth control before they leave the hospital. I can give them a shot of Depo the day before they leave the hospital. That gives them 3 months of birth control. I can send them home with a prescription for birth control. All patients should have access to birth control. That will give them, I can give them a year's supply of birth control before they leave the hospital. Encourage patients to advocate for themselves. The birth control that we prescribe, whether that be the mini pill or Depo, does not impair breastfeeding at all. It's progesterone only. We tell them when to start it, they go home. Even if they never fill it, they have that option as well. A lot of women don't make it to their postpartum visit. If they have multiple children, they have a newborn, who can pack up their newborn and drive with their other children? So giving them access to postpartum birth control before they leave the hospital is a really great option. The nurses know when I round, who's getting Depo today, Dr. Green? Room 6, 7, and 8 are all getting Depo today. It gives them 3 months of birth control, and that's a really great option. So we have to advocate for our patients to make sure that they have access to birth control. STIs. Everybody's favorite topic, right? In 2023, 2.4 million cases of syphilis, gonorrhea, and chlamydia were reported. When I did this talk before, I put the counties in Florida. I was lecturing to an MPH class, and I had our specific counties of the cases of syphilis. My class was floored, because you could see like 500 cases of syphilis in this county. 800 cases of syphilis in this county. It's really shocking when you look at the statistics. 3,800 cases of congenital syphilis, including 279 congenital syphilis, stillbirths, and neonatal infant deaths. Most of those cases of gonorrhea, chlamydia have decreased over the last few years. Syphilis has continued to increase. I want to say that one more time. Syphilis has increased in the United States over the last 10 years, pretty dramatically. We think that that's a gross underestimation of the 279 congenital syphilis stillbirths because when we have fetal demises, oftentimes the majority of them aren't tested for syphilis. We think that majority of the stillbirths can be related to syphilis. Only about 40% of stillbirths are tested at the time for syphilis. STIs, as we know, can significantly affect a woman's ability to conceive and increase complications during pregnancy as well. Pregnant women risk transmitting STIs to the baby at the time of delivery and during pregnancy. Rates for STIs were lowest for women that received prenatal care in the first trimester, and so this is where access to care is really, really important. We want to make sure that they're getting prenatal care in the first trimester. Untreated STIs can lead to fetal death, premature delivery, premature rupture of membranes, low birth weight, neonatal eye infections, which can lead to blindness, neonatal pneumonia, and mental and physical and developmental disabilities in the neonate. So this is the rate of STIs. Florida chart still STDs. It's been changed officially to STIs in 2023. You can see where Broward County sits. Red is the highest in the state. Broward County is pretty high. I'm in Alachua. We're also pretty high as well in orange. It's pretty high. Now, this is not in pregnancy. This is just per 100,000. I think that this is really interesting. So when we talk about STI testing in Florida, strongly recommended, actually required to have STI testing in Florida, particularly STIs and HIV. Women should be offered, they can opt out of HIV testing. We have to get consent twice. Somewhere in the first and second trimester, and if they haven't had it at 28 weeks, they have to get it at the time of delivery. Look at how many women were offered to HIV test. 33%. The women that received to HIV test, 26%. These are women that are getting regular prenatal care. That's a problem. And this isn't on the patient's part. This is on us as providers. We're not doing what we're supposed to do. And why? I don't know. I have a lot of reasons to think that. I think that we're just not stressing the importance. We're not empowering women. I think that when we start educating and empowering women, they'll ask for it more often. I don't think that women are opting out of it. When we screen women, they're usually very quickly, yes, I want an HIV test. We're not doing what we're supposed to do. We have to do better. Birth to mothers initiating prenatal care in the first trimester. I have Alachua on there because I wanted you to see where we're at. Broward County is really the same. It's gone down over the last 10 years significantly. When I looked at Broward County's data just recently to women initiating prenatal care in the first trimester, it's gone down. And if we talk about women with no prenatal care in the entire pregnancy, about 10 years ago, it was about 4%. Now it's about 9.9%. It's going up. And it may not seem like a lot, but if you calculate 9% to 10% of how many pregnancies that you have, it's around 10%. It's going to get worse. It's going to get a lot worse. We have a relative OBGYN shortage. There's lots of reasons for that. Many of my colleagues that live up north cannot believe that I'm still practicing in Florida. It's hard. It's hard to practice just in the South in general. The majority of OBGYNs are older, so they're retiring. So there is a huge shortage, and it's going to get much, much worse. So no prenatal care in the first trimester and no prenatal care period is going to increase dramatically. There's been labor and delivery shortages throughout our area as well, and shutdowns as well. As more labor and deliveries close, the OBs then leave. And if their labor and delivery shuts down, they go to other states. I have a lot of licenses to telemedicine. I get, on average, 4 to 5 calls a day for locums, meaning that other states that need work everywhere. The demand is very, very high for OBs right now because of the shortage. This is birth to mothers initiating prenatal care in the first trimester. This is what we just talked about. Syphilis. We talked about the syphilis cases, congenital syphilis and related stillbirths, largest since 1992. Syphilis continues to increase as well. And we're not doing enough testing. So if that's how many women were offered HIV testing throughout the pregnancy, it's the same for syphilis as well. So we're not diagnosing it because we're not testing. And these are women with prenatal care. We're just not testing. More than half of people with congenital syphilis-related stillbirths receive no prenatal care, unknown prenatal care, or non-documented. This is the interesting part too. So even women that get prenatal care, 34% of people did not have a syphilis test at their first prenatal visit. Why is that? I can tell you with certainty that the majority of those women were Black and brown women and indigenous women that didn't have syphilis testing, and they were most likely on Medicaid because I've looked at the data. What can we do? We educate and we empower. We tell women what they need at their prenatal care visits. We tell them what labs that they need. We tell them to advocate for themselves. That's how we improve outcomes. Like we said before, we have been here before. Just like Chanel said, we've been here before. But the difference is that we have to really educate and empower women to take care of themselves. We also have to take care of ourselves. The work does not change. How do we improve access to care? Identify barriers in your prenatal care in your community. At dinner last night, we were talking about zip codes. So I did that in Alachua County. There was one zip code in our community that had the lowest rate of prenatal care in the first trimester. And why was that? It was because of our bus routes. Our bus route did not run to that area, and so they could not physically get access to prenatal care. How did we improve that? There's one of two ways. You can change the bus routes, or you can plan a satellite clinic there. It's very hard to change the bus routes, but we could put a satellite clinic there. And that's what we did. And guess what? The prenatal care went up. It's not that people don't want prenatal care. They just need help getting access to it. And I know that you can do the same thing here. I know that you have done it as well. So you have to look at what are the barriers to care and make it happen. Other places that I've worked, the barrier to care was childcare. So we started centering in the military. That was the biggest thing, is husbands were deployed and women had no one to take care of their children for visits. And oftentimes you cannot bring children to ultrasound appointments. You cannot bring them to visits. And so with centering pregnancy, with group prenatal care, you were able to get free childcare. If you signed up for centering pregnancy, you had free childcare for every single one of your visits. That's a way to improve access. And then we had morning, lunch, and nighttime centering visits. That's what we did. You have to work around women's schedule. I have a child that wakes up at the crack of dawn, literally every single day. And so I started my clinics early to meet patients so that they could come in before work. You work around people's schedule. And then I have some that like to sleep late, some physicians, so they have evening hour clinics, or they have Saturday clinics, or you allow them to bring their kids to the clinic. It is not the end of the world. Work with community partners to overcome barriers. We talked about that in the last session. You empower and equip women and families to advocate for themselves to address differences in care. Women need to feel heard and seen to get better care. Questions. We have about 10 minutes for questions. I think that's a really good question. I think that may be part of it. We do tubal ligations after vaginal deliveries as well. It's a very simple procedure, and so I think that could be part of it, women wanting tubals. I think that women, the increasing C-section rate in Florida particularly, in looking at the C-section data, Florida has some of the highest C-section rates in certain counties in Florida, not because I think we're trying to control women's bodies, but because of the legal landscape. OBs are scared. It's not an easy life. We get sued very easily. And so women are wanting C-sections in certain parts of Florida as well. If you have a community hospital or a private hospital, you have to have an OB in-house 24/7 to offer a VBAC. Vaginal birth after C-section, you have to have anesthesia in-house 24/7. You have to have the surgery team in-house 24/7. A lot of hospitals cannot do that. And I have to be in-house 24/7 as well. I can do that in an academic hospital. I do 24-hour shifts. I can do that. Private practice docs cannot do that. They do not stay in the hospital 24/7. And so I think that it's more about OB hospital being able to offer it, which is why the rising C-section rates. Florida has the highest C-section rates, a couple hospitals. Texas has a couple of C-section rates, and those hospitals, when you look at the data, it's actually because they're single solo practice OBGYNs. They practice by themselves, and they just don't offer VBACs, and that's why it tends to be higher.
Okay, we have one more question, and then we are going to keep some time for the evaluation component. Thank you. What are some options for sterilization in women without insurance?
That's a really good question. So women qualify for emergency Medicaid for 45 days if pregnant, and so they can still get that tubal sterilization at the time of delivery if they've signed the federal form. And now emergency Medicaid is 45 days, so they can still get the tubal ligation right after delivery, or they can do an interval tubal sterilization, which means that they can do it about 4 to 6 weeks after delivery. So those would be the only options if they don't have insurance. IUDs are great options, though. The benefit of IUDs, intrauterine devices, they are as effective as getting your tubes tied, completely reversible, periods are lighter, less painful, and you can get those at your local FQHCs with no insurance on a sliding scale. So if you cannot get permanent sterilization, IUDs are great options. I always like to say tubal ligations are fantastic. However, your periods will go back to whatever they were before. So if you have heavy, painful periods, they're going back to that. Whereas IUDs are as effective 8 years now, and they will make periods lighter, less painful. So for women that don't have insurance, IUDs may be the better option if they cannot get it during that 45-day emergency Medicaid period. It's really challenging. A lot of the symptoms are similar. You're postpartum, you're exhausted, you have weight gain, you have the brain fog, and so it can be really challenging. And so absolutely advocating for yourself with your in-person provider can be key, and we can definitely talk about it offline as well. Thank you.
Thank you so much, Dr. Green. Another round of applause. Thank you. Thank you, everyone, for being with us during this very important session, very important topic. And yes, the comment was important. We do have, as you see in the data reel, a lot of older women giving birth, and it's shifting. We used to have a lot more younger. The teen pregnancy rates are going down, and the older women, that women are waiting or delaying pregnancy to an older age. So please take a moment, scan the QR code, and complete your evaluation now. This will be the opportunity for those of you who need CEUs to make sure that your CEUs are accounted for, and so that we also collect your feedback. If you have an additional question, there is a spot in that evaluation survey that will allow you to enter your question so that we can keep the conversation going. Okay, again, thank you so much for your being here and for participating. And after this, we'll have another 15-minute break. You'll have the opportunity to visit more of the exhibitors, and then we will be back at 12 for our lunch hour and our honoree moment. So thank you again, and we are here. If you have any questions, be sure to complete that survey. Thank you.
All I know is 10:35, and I'm thinking, God, you found me, that you found me. Every day I go places in my head, darker thoughts so hard to know, they look like monsters under my bed. And every time it's like a rocket through my chest, the TV make you think the whole world's about to end. I don't know where this night is going, but I know that you and me are something.
quick interruption. I'd like to invite everyone to exit this room at this time and visit with the exhibitor hall. The amazing staff at the Hard Rock is going to take care of our lunch setting. So please, we ask you if you could please exit the room to go ahead and enjoy the mingling so that we can get ready for the lunch hour. Thank you so much.